part of CTCA before, so I've been here for about 10 years. And me and Dr. Khan, we're gonna try to cover today some advancement in the treatment of pancreatic cancer. So the pancreas is a gland that's in the abdomen, and I know you might know some of this, but I'm gonna go through a brief overview of pancreas in general. So it has two functions. It has a exocrine function and endocrine function, and so there's more than one type of pancreatic cancer. And today we're going to focus more on the pancreatic ductal adenocarcinoma, which is the more common one and the one actually more aggressive one to treat. We're not going to, at least from my perspective, I'm not going to talk much of pancreatic neuroendocrine tumors, which are a separate set of tumors, usually treated differently to a certain extent. So pancreatic ductal adenocarcinoma is basically the cancer that starts in the ducts, in the pancreatic ducts. In general, what are the, what can increase the risk of pancreatic cancer? And the usual culprits are there: smoking, tobacco, heavy alcohol use. Usually anything that can cause inflammation could increase the risk of pancreatic cancer. So repeated episodes of pancreatitis could increase the risk of pancreatic cancer. If there's any major contact with the cancer-causing chemicals like pesticides, also that could cause the increase of pancreatic cancer. Certain other health conditions like diabetes and chronic inflammation, patients that have repeated episodes of pancreatitis for different reasons could have increased risk of pancreatic cancer. And in about maybe 1 in 10 patients, pancreatic cancer could be familial or genetic. That means either it runs in families for reasons we don't know, or sometimes with certain identified genetic mutations that could increase the risk of pancreatic cancer. Please feel free to if you have any questions, please feel free to ask it at any time. I'm okay to have questions and stop, pause the presentation. If I don't know the answers, I'm sure Dr. Khan will. As far as presentation, how pancreatic cancer presents, we can talk about the symptoms. So the pancreas is a gland that spans from the left side of the abdomen to the right side of the abdomen. And here we see in the inset more like what we call the head of the pancreas. So the head of the pancreas will be toward the right side. There's what we call the neck, and there's a body and the tail, which are toward the left side of the abdomen. And this is an inset of the head of the pancreas, and this is what we can see is a bile duct. And that bile duct basically drains the bile from the liver to the intestines that helps with digestion also. And you can see the bile duct and the pancreatic duct both join to empty in the small bowel, the first portion of the small bowel, what we call the duodenum. So the reason, the way pancreatic cancer presents, which most of the time the presentation, whenever they present, they are advanced. About 80% of the patients, whenever they present with pancreatic cancer, the disease sometimes has spread outside of the pancreas. So surgical resection is not a good option at that point. So pain is one of presenting symptoms, and whenever pain happens, usually it is more like in the epigastric area, radiates to the back. It's very nonspecific to a certain extent. Weight loss could happen also with pancreatic cancer, either from the cancer itself, or sometimes patients cannot eat very well whenever they have certain forms of obstruction. Jaundice is when patients turn yellow, and that sometimes could present also with dark urine, or change in bowel habits, more like stools that float in the toilet. And the reason jaundice happens is because of the obstruction of the bile duct. This way the bile backs up and causes the jaundice. Whenever patients present with symptoms suggestive of pancreatic cancer, usually abdominal pain, if there's any significant concerns about, the usual abdominal pain, it could happen something that persists for a long time, or patients that have jaundice, or they have some weight loss, then your doctor might initiate some additional testing. That additional testing, other than the physical exam, could include blood tests, imaging, endoscopic procedures, and biopsies. Most of the blood tests that we do have to do sometimes with liver functions, and usually whenever patients have pancreatic cancer, sometimes the liver functions are not normal. Not all the time, but sometimes it is. As far as for the imaging, multiple modalities could be used. It could be a CT scan, ultrasound, or MRI of the pancreas or the abdomen, And this is how sometimes we find out about pancreatic cancer. Endoscopic procedures are actually very useful in the setting of pancreatic cancer for both diagnostic and for sometimes therapeutic purposes. And we'll talk more about the therapeutic part later on. But for the endoscopic procedures, the physician will, under some form of sedation, will insert an endoscope from the mouth into the stomach. And from there on, they can potentially, some of these scopes have an ultrasound attached to it. From that ultrasound, they can ultrasound the pancreas, and usually they can stick a needle into the lesion itself and get some tissue diagnosis. And the tissue diagnosis, what we call a biopsy, is very important from multiple perspectives. First, from treatment options. And the other part is important also, we can get some more tissue for what we call genomic profiling. This way, sometimes that could dictate certain treatment options also is available for you. I'm sure Dr. Khan will visit on that a little bit later too. Any questions up to now? We'll keep going.
So is it more common for the tumor to be on the head of the pancreas, or I wasn't sure what kind of, you described like the most common type of pancreatic cancer.
So you're correct. Usually the head of the pancreas is the most common, then the body and tail, and the neck will be the least common.
Okay, because that's mine, it was on the head.
Yeah.
So I'm post Whipple. I just had Whipple, like it'll be 10 weeks Friday.
You're looking great. You recovered very well.
I don't feel great because I'm doing chemo and I feel like this is my first good day. But thank you.
That's great. That's great. And so after we establish the diagnosis of pancreatic cancer with a biopsy, we take the tissue, the pathologist will look at the tissue and establish a diagnosis. Then at that point comes the the appropriate workup for staging and for us to determine what's the best treatment plan. So as I mentioned, about 80% of pancreatic cancer patients come in at the point of presentation where basically the disease has spread outside of the pancreas. So surgical resection usually is not a good option. And usually at that point, most of the time the treatment will consist of systemic chemotherapy or sometimes radiation. As far as the workup we do, imaging modalities, CT scans, MRIs, and ultrasounds. Usually CT scan is the most commonly used. And based on that CAT scan, once it's reviewed, because the pancreas is surrounded by major blood vessels in the abdomen that are very important to supply blood to the intestines. So if we look at the CAT scan to see if the cancer is usually resectable or not. So that's the main criteria we look at. Endoscopic ultrasound is also used to determine resectability of the pancreatic cancer. And I'll always mention also, it's very important, like the functional status, like is the patient, how much functional the patient from the standpoint of taking care of themselves, how much they can walk, how much they can exercise tolerance they have. And definitely the better the functional status, the better the chance that surgery could be done if the disease is resectable. We also look at blood tests with tumor markers. And in certain situations, we do laparoscopy if we have a high suspicion that the cancer has spread inside the abdomen and the CAT scan does not show it. Remember all these studies we do, CT scans, MRIs, they have their own limitations. And sometimes anything less than a 5 millimeter to a centimeter, it could be missed on imaging. So that's why sometimes we perform a laparoscopy to see if the cancer has spread inside the abdomen in certain cases. As far as the staging, I'm not going to go in detail about the staging, but it was 5 stages from 0 to 4. It's unlikely to diagnose pancreatic cancer at stage 0. And as you know, as we progress for stage 4, that means the cancer has spread outside of the pancreas itself. And at that point, it's stage 4 disease. It's stage 2 and 3, maybe there's an involvement of lymph nodes. And usually whenever potentially we think lymph nodes are involved, then there's always more indication for systemic chemotherapy before surgery. And as far as genetic testing, and I'm going to just touch a little bit on that part, and I think it's an important part in the treatment of pancreatic cancer. In general, most patients with pancreatic cancer, maybe it's better to see a genetic counselor. This way they can discuss if genetic testing is necessary for them, especially if there is a higher risk or there's other family members with genetic cancer or with pancreatic cancer in the family. And germline mutations is basically what we define as those are genes that are inherited from the parents, and usually genetic counselor will talk to the patients about the implication of testing and what kind of testing is appropriate to be done. Somatic mutations is what we call genomic profiling of the tumor itself. And this is what we're looking at, the genetic changes of the DNA of the tumor compared to DNA in healthy tissue. And the importance of that also, because sometimes certain treatments will be tailored depending on the genomic profiling. At the same time, it is important for clinical trial purposes also. Microsatellite stability are specific proteins that are used in repairing tumor cell DNA. And it's important to test for that in all pancreatic cancer patients also, because it does have treatment implications too. And sometimes if they are abnormal, it might be tied to certain genetic syndromes. I know these are busy slides. I'm not gonna go in detail about that part, but screening for pancreatic cancer, if there's certain, if after genetic counseling and genetic testing is done, and it's determined that there is a higher risk for pancreatic cancer based on genetic testing, at that point, there is some recommendations being developed about what's the best guidelines for the screening for pancreatic cancer. And most of the time that involved could be endoscopic ultrasound, MRI, or CAT scans. And usually MRIs, RCPs, which are studies done mainly with the MRI purposes, are more done than CAT scans. And usually most of these imaging procedures are done in about a year or so, and usually it depends on the genetic cancer itself, which kind of cancer it is. Then potentially the screening is done at separate age groups. The goal of the screening is to detect pancreatic cancer early. At the same time, is also for detecting precancerous lesions where they can resect it early. There's multiple familial syndromes and genetic syndromes associated with pancreatic cancer. I'm not going to touch base on all of them, but we can talk about the BRCA mutations if you heard about that in breast cancer. So patients that have BRCA mutations are at somewhat increased risk for pancreatic cancer. Some patients that have family history of melanomas or personal history of melanoma, certain colon cancers like Lynch syndrome or uterine cancer could increase the risk also of pancreatic cancer. Treatment of pancreatic cancer in general is, as always, it has to be multidisciplinary. That means we have to have multiple specialties involved, and I think it's always very essential, including also tailoring that part of the treatment for potential clinical trials. So it involves a medical oncologist, a surgeon, radiation oncologist, supportive care, genetic counseling, GI physicians, and definitely multiple other entities could be involved with the supporting the cancer patients. So the treatment could involve systemic chemotherapy or systemic therapy in general, surgery, radiation, and I'm going to try to touch base about the surgical component, and I know Dr. Khan will touch base about the medical oncology component. So we try to define pancreatic cancer based on imaging, as I mentioned, into resectable disease, borderline resectable, and sometimes what we call locally advanced. Locally advanced is a disease basically that's usually is not resectable, even though it hasn't spread into the abdomen like the liver or the lungs, but it's basically unresectable because it's invading into major blood vessels. So around the pancreas, there's multiple major blood vessels. So when we look for resectability, we make sure that those vessels are not involved. If they are involved to a certain extent, then we call it borderline resectable. And at that point, surgery is still an option, usually after systemic chemotherapy. If the disease is resectable on the CT scan images based on our review, sometimes we still recommend systemic chemotherapy up front. And that's definitely have its pluses and minuses. Usually for me, I always recommend for patients to have systemic chemotherapy before surgery. But there's no data to suggest that having systemic chemotherapy before surgery is better or worse. It's more like a recommendation based on our experience in general. But in general, I recommend systemic chemotherapy before surgery. Once we deem the disease resectable, then usually we go for surgery. Surgery could be done minimally invasive, robotically, or open. In general, most Whipple procedures are done open. If the disease is actually in the tail of the pancreas or the body of the pancreas, that sometimes is usually, most of the time, is done robotically. In certain patient populations that have early stage disease, if there's advanced disease, usually open procedures are being done more than robotic procedures or minimally invasive procedure. So if we look at this picture, I'm trying to explain a little bit about the Whipple procedure. So that's the liver over here, that's the gallbladder, and it's what they call the common bile duct. And here we see the pancreas behind or posterior to the stomach, and the duodenum, which starts over here. And this is what they call the first portion of the small bowel jejunum. So the dotted line marks the area of the resection, where we take the head of the pancreas and we take the duodenum, sometimes part of the stomach also, and we take the gallbladder and the bile duct. And after that, after the resection is done, then the pathologist will be in the room. We review the pathology. We review the, whatever resected with the pathologist to make sure the margins grossly looks normal. And we do what we call the frozen section to make sure that, in general, the microscopic margins looks okay also. And after that, we'll start with the reconstruction. So we bring this loop of bowel from here, and we connect it to the pancreas, to the bile duct, and to the stomach. Or sometimes if we do what we call a pylorus preserving Whipple procedure, then at that point we save the stomach and we do a anastomosis to the pylorus, which is the first portion of the small bowel. In general, most of my Whipples, I do them with resecting a small portion of the stomach. I like to take the pylorus out. Usually, if we leave the pylorus, patients have what we call gastric emptying issues. And sometimes there is delayed gastric emptying because we leave the pylorus behind. It's either or. It's okay to leave the pylorus behind in certain situations, but in general, for us at CTF Hope in Chicago, usually we always tend to take the pylorus out. And if the disease in the distal part of the pancreas, usually the spleen is in this area. Usually what we do, what we call a distal pancreatectomy and splenectomy. So quality of life after Whipple procedure, I always, tell my patients in general, it depends what the functional status or, before the surgery. Usually if they have very good functional status and they're very functional in general, then the recovery process is faster. And in general, as far as, chronic conditions associated with the Whipple procedure, delayed gastric emptying is one of them, but usually most of the time that resolves with time in about 3 months or so. Some patients would require pancreatic enzyme supplementation, especially right after surgery to a certain extent. And that depends on how much of the pancreas we do resect. And in patients that we do like a Whipple procedure or distal pancreatectomy and splenectomy, about maybe 1 in 5 patients will develop diabetes at some point during their lifespan.
And that's what
could be common. Go ahead, I'm sorry.
No, I'm sorry to interrupt. But
No
that's
worries.
like, this is like way over the top. Yeah, it's like on the top of the chart.
Weight loss could be common sometimes too, but usually most patients, once they recover from surgery, they could regain their weight. One of the most common acute complications after pancreatic surgery, especially Whipple procedures, is what we call a pancreatic leak. Most of these pancreatic leaks actually resolve on their own with conservative management, usually with drainage and making sure the nutrition is well, and usually does not require repeat surgery. As far as what are the stuff we look at for as far as prognostic factors, definitely the stage of the tumor at presentation, the higher the stage. Usually the prognosis is not as good as if it's with the early stage tumors. We look at the tumor markers, the CA19-9, if it's significantly elevated, and basically there is no evidence of blockage of the bile duct. It also could be associated with systemic disease that we don't see on imaging. So that's why if the CA19-9 is elevated, and even though it's a resectable disease, we're going to recommend systemic chemotherapy up front. If the patient is still smoking during the treatment process, what kind of tumor it is, what we call the biology of the tumor, if there's any lymphatic invasion, vascular invasion, all of these things are important prognostic factors. I will add to that also the functional status of the patient. If the patient have very good functional status, usually they fare better. I think it's an important aspect to talk about in pancreatic cancer is improving quality of life, and sometimes there's lots of supportive elements that could be done to improve quality of life. For example, for pain, there's something called celiac axis block. Even if the disease is not resectable, then celiac axis block could help with pain control. And sometimes palliative radiation is also used to a certain extent in certain patients. If there's intestinal blockage, I think at that point it's a discussion that should be done between the physician and the patient about surgical intervention. If it is actually in the proximal part where in the duodenum, sometimes we can divert the stomach to a small bowel, and I think that's a simpler procedure. But if the disease has spread inside the abdomen to involve what we call the peritoneal cavity and the lining of the abdomen, at that point, I think it should be a reasonable discussion between the physician and the patient about how much the surgical intervention is warranted or how much that's going to be helpful. We talked about the ARCP and stent. especially with patients that have jaundice. Usually it's recommended for them to have a stent placed in the common bile duct. This way we can decompress the liver and allow the bile to flow through, and that will help with digestion and resolve the jaundice. Certain patients that have weight loss, pancreatic enzymes are used, and nutritional concepts is also very helpful from that perspective. So I think at this point, I'm done with my slides.
Those patients that receive chemotherapy after surgery, what treatments are what we normally give and why we give them. Then in patients with stage 4 pancreatic cancer, the options of treatment there, sort of the second line treatments, in other words, patients that have already received the first line of treatment and the cancer has progressed, what's the next line of therapy? What are those options? And then the evolving treatments that we have right now, plus potential targeted treatments or genomic-based therapies that we have. Next slide, please. So currently, as of 2021, this is the data that came out of the SEER database. About 60,000, or a little over 60,000 patients are diagnosed with nearly 48,000 deaths per year. Unfortunately, it still remains the fourth most common cause of cancer-related death in both men and women. And as we know, the incidence, at least for the past 20 years, has been rising. And Dr. Halabi certainly delineated some of these things, which is unfortunately aging, obesity, smoking, alcohol consumption, and type 2 diabetes. What unfortunately has not changed in the past 20 years has really been the effect of mortality in terms of improving that with our current treatments and our current algorithms. The other thing we do know is that there are specifically germline mutations that are identified in pancreatic patients, pancreatic cancer patients, which are the BRCA family, which is the BRCA2, which everyone sort of knows is linked with ovarian, prostate, and breast cancer, but are also the precursor genes, particularly ALB2. And then in sort of the Lynch syndrome family, which we call sort of the microcytal instability, which causes cancer, MLH1, MSH2, MSH6, and PMS2, which all occur kind of in a network or a satellite family. And then what we also see commonly in pancreatic cancer patients, and they're particularly the specimens, when we take the biopsies or from Whipple surgeries, we see a number of patients with CDKN2A, which occurs in about 30 to 40% of patients. The majority of patients will have something called TP53, and then up to 10 to 20% of patients will have STK11 as a mutation within the cancer itself. And these also do occur within the germline and can be familially related in pancreatic cancer syndromes. Next slide, please. So essentially kind of what happens in the domain of the pancreas. What happens and what sort of results in cancer is kind of highlighted here. This was originally thought of, way back in the early 90s, and then kind of capitulated later on into the early 2000s. And this was published in the Clinical Cancer Research Journal in 2017. So what you see at the very top there is the KRAS mutation. This mutation occurs in about 95% of all pancreatic cancer patients. And this is what we believe is the predominant harbinger in terms of causing cancer. And what we normally see on the very left is normal pancreatic tissue, normal pancreatic cells, the lining. When patients develop what we call intraepithelial neoplasia, which is the first portion of cancer that starts to develop, you notice a KRAS mutation in there. And those cells, and we highlight this by changing color, they start to become more darker, obviously, based on the representation here by the cartoon. But what's happening is that those cells are getting larger and elongating. And then when they go into a more dedifferentiated form, which is the intraepithelial neoplasia 1B, you can see the patterns change and they become less columnar and we call more palisade. And then further mutations occur, which then cause them to become into more intermediate and then more high-grade states of basically neoplasia. So in other words, not fully cancer yet, but they're transforming into cancer. And essentially, you can start to see that there's a loss of symmetry, and then these cells start to bud off and then start to invade underneath the basement layer of the cell membrane. And then you can see in the very right hand, as you get these other chromosomal alterations and mutations occurring, you basically develop pretty much all these cells that start to harbor the KRAS mutation, and now they're invading into the basement layer. So this is kind of a synopsis of essentially sort of what happens and the challenges of sort of diagnosing this early on, which is this events could take anywhere between months to years in some patients versus days to weeks in others. And so it depends really on the severity and also how quickly these cells transform. Next slide, please. So the challenge right now that we're facing essentially is looking at both animal and human models in terms of how this cellular development occurs. The other problem that we notice in pancreatic cancer is that these cells can become cancerous with the lowest percentages of cellularity. In other words, they don't need a ton of cells to develop cancer. They can start to develop in a very few amount of cells. The other thing that we have a difficulty with treating with this disease is that in a lot of cases, there's not a true target. In other words, not each of the cells represent the same mutation, and they don't necessarily harbor the same mutation, which makes it difficult for us to treat it with just one form of treatment. Next slide, please. And this is kind of an understanding, and this is a data set that we obtained in a couple articles here, but these are large genomic companies that panel pancreatic cancer for us. And so these are taking from tissue, on the left-hand side from 616 patients, on the right hand, 833 patient panel. Interestingly enough, you can see there's a litany of mutations, but up to 17 to 25% will actually harbor homologous pair or DNA damage response mutations, particularly BRCA1 and 2 and ATM. These are targetable mutations. We have drugs for these, but you can see it's not the wide proportion of them, and unfortunately a minority, and that's what makes it challenging for us to pick one drug specifically to treat the cancer. Next slide, please. So the other aspect of this is that because these mutations do occur, and we can see them up to a quarter of patients, the recommendation really is that all patients with pancreatic cancer who have a confirmed diagnosis should have a comprehensive panel for hereditary evaluation for possible hereditary cancer syndromes to see if there is one underlying which is causing the cancer. Next slide, please. And to give you an idea of sort of the synopsis of where we are right now, and sort of stage by stage in survival, majority of the patients obviously, unfortunately, have stage 4 disease. They have distant disease, up to 52%. But as you can see, the 5-year survival for distant metastatic disease, even to this day, is less than 3%. Versus those patients that have very localized disease or caught very early, that can be about 10% of patients with a 5-year survival of about 34 to 35% in most cases. So unfortunately, there's a significant challenge here, and there's a lot of opportunity here for us to improve. It's been a real struggle in terms of just figuring out exactly how to treat the disease and knowing all the different mutations that can occur. And more importantly, diagnosing the disease earlier so we can get more patients to surgery early on.
Dr. Khan, what is the date of this survival rate data?
So this was pulled from the SEER database, so it's a national database. So the SEER database basically looks at essentially all the diagnosed cancers by the Medicare database and publishes based on that.
What is the date of this last SEER release?
This comes directly from the essentially from CMS, or the Center of Medicaid and Medicare Services. So they publish these guidelines, or not guidelines, but the actual data, survival data, and stage per stage data. So they're publicly available.
Okay, thank you.
My pleasure. You have any other questions, Jeff?
No, not yet. Thank you.
Okay, no problem. No problem. So this is just a synopsis of the mortality data, and this to kind of give you the scope of the problem in comparison to the other cancers. And you can see lung cancer, which has the highest risk and highest rate of mortality still, but even though the cases of colon cancer are tripled in comparison to pancreatic cancer in incidence, the actual mortality is still the same. And so this is still the third most common cause of cancer death in the United States. even to this day. Next slide, please. So let's talk a little bit about, and Dr. Halabi did a great job in terms of describing the resectable patients. And this is kind of how, when patients come and see me in the office, when we discuss cases at the tumor board, we kind of define them based upon resectable, in other words, patients that can have upfront surgery, borderline resectable, in other words, patients that could be resectable may need treatment up front. And Teresa kind of described that a little bit, right, in her case, where they may not be able to have upfront surgery right away and may need chemotherapy up front. And then those patients that are unresectable or potentially metastatic, and we'll talk about the options of treatment here. So the consensus really, this was developed back in about 2018, and what we talked about really was who are the borderline resectable cancer patients. And what we look at really, like Dr. Halabi was pointing out, was the CT factors. So in other words, how close are they to the vessels? Do they incorporate the vessels? Is there less than 180-degree wrapping around one of the major vessels, such as the superior mesenteric artery, celiac plexus, or hepatic artery, which are the main arterial supplies around the pancreas? The other thing is, what we look for is also the biological factors, which may not be seen on CT or PET scan, particularly a CA19-9 of less than 500. Obviously, the other conditional factors may include biological factors such as the age of the patient, comorbidities, overall performance status, in other words, how well they're doing day to day, what factors may play into whether they can tolerate the surgery, and more importantly, survive and have a good quality of life afterwards. And so these things are very important in terms of making a distinction of who can have surgery and who would be a surgically elected candidate for having surgery as well. Next slide, please. So essentially, this was the first clinical trial that was done, I would say, in the past, after about 15 years, there were no clinical trials that were really done that were positive. And then this trial was done in France, and the trial really was to compare, which was at that time the standard of care. So patients would have surgery, and then they would receive gemcitabine for approximately 4.5 months as quote unquote adjuvant therapy or treatment beyond surgical treatment to maintain cure. The treatment here was a 5-drug regimen, which is called FOLFIRINOX, and they compared this to gemcitabine. And what they wanted to do was basically look at patients that had complete resection, and then they would follow them up with CT scans every 3 months. And the endpoints of this were both survival and disease-free survival for following surgical treatment. Next slide, please. So the toxicity, when they looked at it after completion of the phase 3 study, what they found was there was a significant amount of hematological toxicity. In other words, patients suffered from neutropenia. 5% of patients had febrile neutropenia, which is they were admitted to the hospital after having severe low blood counts, and up to 9% of patients had low platelets in comparison to the Gemzar arm, which were almost half, if not three times less. There was also a significant amount of fatigue, diarrhea, also neuropathy, and elevated liver enzymes that did occur on this study. Next slide, please. And then the other trial that was done just following that study was looking at the same arm of gemcitabine as a standard arm versus a doublet, but not a quintuplet, but a doublet arm, which is Abraxane or nab-paclitaxel, given weekly in combination with gemcitabine, and similar patient population, and also the disease-free survival and overall survival were looked at in this trial as well. Next slide, please. And the survival curves on this chemotherapy regimen were, as you can see, disease-free survival almost 20 months in comparison to 19 months, but the overall survival was almost 3 years in comparison to, over 3.5 years in comparison to 3 years for the nab-paclitaxel and gemcitabine arm. So it was statistically significant, which ultimately gained the FDA's approval in terms of approving this for patients following surgery. Next slide, please. Now, the one slide that we somehow got missed was the FOLFIRINOX slide. In that slide, they showed a 2-year survival benefit versus Gemzar alone. And so both of these basically became approved by the FDA by these 2 large trials were done as multinational trials. And basically FOLFIRINOX, which is the 5-drug regimen, or the 2-drug regimen, which is gemcitabine and Nab-paclitaxel, became approved as the standard of care. Also, what we noticed was that despite the toxicities, the standard of care, the quality of life was better, and the overall survival was better based on this data. Any questions about those slides at all?
What is adjuvant chemotherapy? Is that what you're just talking about? Different drugs that are used?
So yeah. And I apologize for the nomenclature, but when we're talking about definitive treatment, it would be surgery in pancreatic cancer. Right. So if we give treatment following definitive treatment, that's what we call adjunctive or adjuvant therapy. So it would be after that to maintain. That means
you get surgery and now you're doing the chemo after.
Okay. You got it.
I thought it was some new treatment. Like, hey, there's something new though.
No, you got it. You're speaking like an oncologist now, right? So exactly. So when we speak to you about it and we say, oh, we're going to give you treatment beyond surgery, we're talking about adjuvant treatment.
Okay.
Exactly. You got it. Excellent.
Thank you.
My pleasure. Any other questions? Otherwise, we'll move to the neoadjuvant treatment. Okay, let's move to the next slide then.
But I have a question. What?
Yes, go ahead.
I was trying to look at the data.
So right back.
Gemcitabine and the Abraxane together has less, side effects, toxicities, things like that. What's the clinical indication for giving the FOLFIRINOX versus the combo of gemcitabine and Abraxane?
You mean why give FOLFIRINOX instead of giving Gemzar and Abraxane?
Oh, you showed a slide where the toxicity and the side effects were higher with
absolutely.
So what would be the clinical indication to give the FOLFIRINOX?
So both those trials were approved in comparison to Gemzar by itself. And so there hasn't been a clear head-to-head trial between the two regimens. What we normally give, when we give treatment beyond surgery, the majority of patients will get FOLFIRINOX because the survival curves were slightly better, despite the toxicity. Obviously, if the patient, if we're a little bit worried about the clinical toxicity of the treatment and the patient may be a little bit frail, we'll usually choose the Gemzar or Abraxane. What I can say really is when we kind of look at them in other aspects, and I'll kind of show some of that data here, they look very similar in terms of efficacy.
Can I ask you a question when you're done?
I'm ready.
I'm not on any of those drugs. So does that mean that's not good, or?
What are you on?
I'm on FLUOROU fluoro RA. So it's FL.
Yeah.
UOR. You know that one. Then I'm on IN IRINOTECA, and then I'm on OXALIPLAT. Is that good?
You are on FOLFIRINOX.
Oh, I am. That is it.
Yeah.
Okay.
Yeah.
Even though I get it, but okay. I was just curious.
So I didn't want to get into all the nitty-gritty details of every single drug, so I kind of used the regimen, right?
Okay. As long as I'm on the right stuff, right?
You're doing great. You're doing great. Yes, you're on the right treatment now.
All right.
Okay. Why don't we go to the neoadjuvant slides? Let's proceed forward to the neuropath study. So the question really kind of came into play here, which was, and this is our standard practice for years, and Dr. Halabi and I practice. And so we generally give chemotherapy up front to patients prior to surgical treatment. A lot of that discussion was that prior sort of retrospective studies showed that this was the best way to treat patients rather than take them up front to surgery. The other thing, majority of patients receive FOLFIRINOX as a preferred treatment beyond surgery, the adjuvant treatment. So this was the question that NORPAC-8, or this phase 2 clinical trial, was trying to answer, was that if we give FOLFIRINOX before surgery, what would be the actual benefit of that as compared to giving it after surgery. So I'll show you just the schema here on the next slide. So this is essentially the schema. So it's a smaller study, only about 140 patients. 63 went to surgery, followed by 6 months of chemotherapy with FOLFIRINOX. And then in patients that received the neoadjuvant or chemotherapy up front, had 4 cycles surgery and then completed the 8 cycles after surgery. And I'll show you the toxicity data first here on the next slide. So let me actually show the outcome first. So the outcomes were that majority of patients that received the chemotherapy first benefited by having a complete resection. Nearly 60% of patients had a complete resection. Up to 30% of patients had no positive lymph nodes at the time of surgery, in comparison to having surgery alone. The other thing was that when they also compared sort of per protocol, it was very similar. So what they found was that obviously prior to surgery, it clearly benefited. Next slide, please. What we did show, however, was that the toxicities, nearly more than half of the patients had significant toxicities. Majority of them had diarrhea and gastrointestinal issues, particularly nausea and vomiting, and then hematological issues such as low blood counts, and then also febrile neutropenia. Unfortunately, 2 patients died receiving chemotherapy prior to surgery. 1 died of a sudden death, and then 1 was a COVID-related death, unfortunately. So this was the only real major issue, was the toxicities when we giving the chemo prior to surgical treatment. Next slide, please. Now, what they did find was that there was no improvement in survival when they gave the chemotherapy treatment. And although it impacted on the fact that patients had curative surgery, in other words, they had complete resection without a positive margin, and more patients had did not have positive lymph nodes, the concern still was that with the toxicities, the investigators on the study did not support it as a standard of care, but did support it as a continual use at this point to impact on patients with borderline resectable cancer to make them resect. Next slide, please. So any questions about that particular giving chemotherapy before surgery? Okay, very good. Now I'll move on to the stage 4 patients and our selection of chemotherapy in stage 4 cancer. So when we evaluate patients, what we're looking for obviously is how well they're doing, what's their performance status. The second thing is their age and other comorbidities, particularly if they have neuropathy up front, cardiac issues, diabetes. Also, there can be particularly plastic stents that can be put in place, which could cause complications during the process of receiving chemotherapy. The convenience and patient preference, some patients will prefer to receive treatment every week versus every other week, and this is another part of our treatment. And then predictive biomarkers that we do use, particularly CA19-9 to other biomarkers that we're using now to determine potential options of treatment for patients in stage 4 disease. So we'll move on to the first line treatment. That'll be our next slide. So this is essentially very similar to what I had shown you with the PRODIGE study, which was the initial one that was done for patients with resectable cancer. Very similar trial design, except these patients were stage 4 cancer. The 2 arms were FOLFIRINOX, which is the 5-drug regimen, in comparison to standard of care at that time, which was gemcitabine alone. And you can see the comparison. The survival in comparison to gemcitabine was greater than 5 months in terms of overall survival. And then in progression-free survival is greater than 3 months. So based upon these trial results, which were both statistically significant, the chemotherapy regimen was approved by the FDA for first-line treatment for pancreatic cancer. Next slide, please. Now, this is a separate study that was done called the MPACT study, and this looked at the other sort of treatment, which is gemcitabine and nab-paclitaxel versus gemcitabine alone. It was done very similarly to the FOLFIRINOX trial, and in this, patients received either gemcitabine and nab-paclitaxel or gemcitabine alone. And you can see the survival benefit was a little more than 1.8 months, and then the progression-free survival was a little bit better than 2 months. So overall, this also gained FDA approval because they were both statistically significant in terms of improvement in the overall clinical outcome of patients with first-line treatment for pancreatic cancer. Next slide, please. So this is just kind of a breakdown, and what we kind of see is that the median age, as well as the predominant sex predominance, location predominance, head, body, tail, number of sites of metastatic cancer, the disease control rate are very, very similar. Obviously, in FOLFIRINOX, the survival was slightly better when you compare them head to head, but the median progression-free survival, in other words, survival to the next line of treatment, was very, very similar in both arms. Next slide, please. Now, this is a new treatment that's been developed over the last 3 years. And like Teresa was saying, she's getting irinotecan, which is part of the FOLFIRINOX regimen. This is a slightly different drug. It's called liposomal irinotecan, which is Nail-Iri. It has a longer half-life. It penetrates into the tumor better. And it has a 46-fold greater exposure than normal irinotecan. It actually gets in the tumor longer and spends more time there. And our assumption is that it would kill more cancer cells by doing so as well. Next slide, please. And so this was a recently published and presented trial. As you can see at the very bottom, it was presented in just last year at the National Symposium for GI Cancers through ASCO. And this was a large multinational clinical trial. And what they compared in this was the liposomal irinotecan component with normal FOLFOX or FOLFIRINOX. Instead of the irinotecan, they would give the liposomal version. And this was compared to gem and nab-paclitaxel, which is the essential standard of care. And 770 patients were randomized on this trial. And the primary endpoints were both overall survival, with secondary endpoint being progression-free survival. Next slide, please. And so in comparison, this did slightly better in terms of overall survival by just over 2 months. And so this has now also become the standard of care for patients receiving first-line treatment. Next slide, please. And this is just kind of just a synopsis of the study where it says it was a slightly higher improvement in survival, but unfortunately there were slightly higher grade 3 toxicities, just slightly higher than nab-paclitaxel. But unfortunately, there was 2% deaths that did occur on that trial as well. And this kind of gives us an understanding of where we are right now in terms of our treatment options for patients with stage 4 cancer. So patients that are in excellent performance status, generally the recommendation has been either the 5-drug regimen of FOLFIRINOX, the new 5-drug regimen, now F.A.C.S, which has just recently been approved by the FDA, and then gem-nab-paclitaxel. In patients that have borderline performance status that may not be able to tolerate all 5 drugs, the recommendation is either gem-nab-paclitaxel or gemcitabine alone. Unfortunately, those that have a performance status of greater than 2, in other words, they're spending more than 50% of the time in bed, the recommendation has been palliation alone, in other words, no chemotherapy. And those that are over 75, the recommendation has not been FOLFIRINOX. The only reason they didn't recommend it was there was less than 2% of patients that were greater than 75 both studies. So the recommendation there has been the 2-drug regimen or gemcitabine. So I'll move on to second line unless there's questions for about the slides at all, or any questions that pop up. So so in second line treatment, basically, unfortunately, up to can we go back to the previous slide? Apologies. Up to 40 to 50% of patients are suitable candidates for post-progression treatment. Unfortunately, for second line treatment, there hasn't been an established standard of care, except really for sort of the FOLFOX, which was our de facto, which was similar to the FOLFIRINOX, absent the irinotecan. Next slide, please. So this essentially kind of formulated the phase 3 study here with patients that progressed after gemcitabine, and they could either receive Nailiri, which is sort of similar to Nailiri-Fox without the oxaliplatinum, or 5-FU-leucovorin, or Nailiri with 5-FU-leucovorin. So it was a three-arm randomized study to see which was the most preferable regimen in terms of improving survival. Next slide, please. And this was essentially Nailiri in comparison to 5-FU-leucovorin. So slightly better improvement in survival by 2 months. And based upon that, it gained FDA approval. There was also significant reduction in the CA19-9 by nearly 40%, with the overall response in terms of reducing the size of the tumor by 17% as compared to 1% with the 5-FU-leucovorin. So based upon this, this became the new second-line treatment for patients receiving gemcitabine-based therapy. Next slide, please. So at present, with our new regimens, along with sort of the new compound of liposomal or nanoparticle liposomal irinotecan, what we notice is that when patients receive FOLFIRINOX, we don't have a clear answer as to what the next line of treatment should be. We do assume, based upon some of this data that we have, what we can treat, but there is not a clear definitive answer. The other thing is that, at least from the preclinical data, we believe that the liposomal irinotecan was a slightly better compound and would get exposed to, cancer to more chemotherapy, but that we just haven't had a pure clinical trial to sort of determine it's truly better than what we have with the irinotecan. And then the Nailiri, we know, has a certain role in patients receiving treatment, but does it have a greater role in patients with certain genetic mutations or somatic mutations? And some of these questions we're still trying to address with clinical trials. Now, the expansion of sort of where we are going with pancreatic cancer is looking at sort of these particular targets at the moment. So initially, 5 to 10% of patients will have a BRCA1 or 2 or PALB2 mutation, which is a homologous recombinant mutation, which prevents proper transcription of DNA from cell to cell, resulting in mutations, resulting in cancer. And then in sort of the second and third line, we right now have drugs for KRAS 12C mutation, yet to have drugs for 12D and R, which are still sort of under development right now. And about 10% of patients may qualify for these drugs. Up to 1 to 2% of patients may have MSI, which will allow them, which is microsatellite instability, which will allow them to receive immunotherapy treatments. Next slide, please. So based upon the BRCA mutation, what we know is that up to about 7% of patients may have a germline mutation. In other words, they harbor that from just hereditary penetrance. And initial data retrospectively showed that there was benefit in patients receiving these drugs following either FOLFIRINOX or gemcitabine and cisplatin. Next slide, please. So this led to a clinical trial called the POLO study, so these patients all finished first-line chemotherapy, had control of their cancer, and then were placed on olaparib, which is what we call a PARP inhibitor, which prevents or allows proper transcription of DNA and prevents the genetic mutation causing problems in the transcription of DNA. And when they gave this drug on maintenance and compared it to patients that had placebo, there was a 4-month progression-free survival difference, with the median survival was actually 2 months better. I apologize for the slide there, but there was just a slight betterment in terms of at 40 months when we noticed the separation of the curves. So it took a while for us to notice the separation of the curves, but there was a slight benefit. Next slide, please. Now, these are selected for what we're looking at right now and what we have available. In patients that have sort of the microsatellite instability, which is a frequency of about 1%, they can receive immunotherapy treatments such as Keytruda or dorzolamab as a potential option of treatment. Studies have shown up to a 30% benefit in these patients. Patients that have high tumor mutational burden, in other words, there's many, many copies of abnormal DNA, which we detect essentially a genomic evaluation, they can also receive immunotherapy treatment. Less than 1% of patients will have some of these other mutations, which are sort of the NTRK, BRAF, RET mutations that can occur but very slightly, but there are targetable treatment, there are targetable drugs for these potential mutations. And then more and more patients that we're noticing now have 12C. Recommendation has been to give them adagrasib, which is trade name Krazati, and then Sotastar, which is trade name Lumakras. These can have up to a 50% response in patients in terms of controlling disease and reducing tumor burden in these patients following chemotherapy treatment. And then sort of what we don't know yet are the NREG and sort of the ALK mutations. These are drugs that were initially developed in lung cancer, but we believe less than 1% of patients with pancreatic cancer may harbor these mutations. And if they do, we don't know yet what the responses are. Some of the studies are still being conducted, and we're still waiting on some of the data, but they do look favorable, at least preclinically at the moment. Next slide, please. So this is kind of where we are a little bit right now, just to kind of give sort of, I would say, a Venn diagram of sort of where we are. So what we do know is obviously chemotherapy is in the background. We're trying to develop molecularly targeted treatments, sort of figuring out what specifically we can use following chemotherapy treatment to allow improvement in controlling the disease. Obviously, 1% to at the very least 2% patients may benefit from immunotherapy, but we're still looking for targets potentially that we can use. And then what we do know is the way this pancreatic cancer grows, it creates a lot of fibrotic tissue around it, not allowing penetration of chemotherapy drugs and other treatments to get into the actual tumor itself. And so for years, what we're trying to do is develop stromal depleting elements, which will essentially erode away some of that fibrous tissue around the tumor and allow it to be penetrated with chemotherapy or other treatments. So some of these things are still being treated. What we do know is that we're still questioning whether pancreatic cancer is truly immunogenic or not. Many feel that it may not really have true immunotherapy value. And so perhaps reducing the amount of stroma may actually help improve survival outcomes as well as benefit in terms of response in the tumor itself. Next slide, please. And so at present, this is kind of where we are right now, where we were and sort of where we're moving. And as we can see here, the FOLFIRINOX arm allows us to get approximately up to 1 year survival. And then additional olaparib, which could be given in maintenance patients with sort of BRCA mutations, may additionally give another 5 months. And then following that treatment, if the cancer comes back, we have gemcitabine-based regimens and obviously clinical trials as well. And so this kind of gives us a little bit of an idea of how the field is in terms of therapeutic sequence and kind of where we need to go in terms of improving our cancer treatments and care right